cervical cancer is something big in our part of the world. It's a taboo subject, HPV. We need to discuss. We need to break the ice about it and then spread the knowledge, educate, screen, identify, vaccinate. Got it?
Hello everyone, and welcome to another episode of the AUD podcast channel. We have a very special guest with us today, Dr. Labib Riachi. Dr. Labib, welcome to the show.
Thank you for having me.
Thank you so much for your time. We really appreciate it. So, Dr. Labib, in preparation for this podcast episode, I got some good recommendations from some people. So I asked the women in my life, if you had a chance to sit down and listen to a podcast, what are the burning questions you want answers to? So what I wanted to talk about today is overall women's health. Of course, we're going to dive into your experience with robotics. I know you've conducted over 1,000 robotic surgeries by now, double board certified. You were the chief robotic surgeon in New Jersey in the US. And through your content, you've been a big advocate on technology and how the advancement of technology not only makes it safer for patients, reduces the pain, and also takes some of the stress, I think, what is not talked about enough, off the doctor himself to be able to do different things or think in different ways. So that's what the conversation is going to be about today. So really, really excited to speak to you and have you on the show. But before we dive into all this, why don't you give all of us a little bit of background about yourself and we'll take it from there.
All right. Thank you again, Khalid, for having me. Talking about women is something that I've been doing for years. We started my journey with my cousin, Corinne, was diagnosed with ovarian cancer at the age of 21. So I was pursuing my MBA and loving life and business and taking over my dad's company until Corinne got hit with ovarian cancer. We were shocked. We're a family that is very close and very cordial to each other. So I decided to drop everything and apply for medical school. So I pursued medical school. Then I wanted to do something about oncology and cancer. And it's going to be OBGYN. So I applied, and here we got in New Jersey, part of Seton Hall University, and I specialized for 4 years in obstetrics and gynecology. I finished, and I had one goal, right? The goal is to pursue GYN oncology. So then I moved back, and I did a fellowship in gynecology, oncology, and reconstructive surgery. And I did this in Atlanta, Georgia. After that, moved back to Jersey, where I was, my alma mater, and I took over the department in OBGYN and headed the division of pelvic and obstetrics and gynecology. During this time, my revenge was what? Taking care of this disease and getting rid of everything that is malignancies in women, especially pelvic floor. So kind of like a vengeance, but this is so positive for other patients because it was a crusade, to overcome ovarian cancer, uterine cancer, cervical cancer, and everything that has to do with it. During that path came along technology and advancement in technology. The robotic technology came in 2001, and many were skeptical about it. It's an expensive machine, it's not gonna work, it's gonna take over the surgeons, and we're gonna be out of jobs. So basically, I was the young kid surgeon in the block with a chairman, he passed away, Richard Osowski, that believed in me. And he said, you know what, why don't you play with this tool? I'm too old to do that. So I started doing it when no one did. And we were a few, back from California, West Coast to the East Coast, and in the Midwest. And we played with this tool, we liked it. We started exercising on kind of fruits, vegetables, pieces of chicken, pieces of meat, and we got good at it before we went and did patients. And when we did patients, we noticed a big difference. We noticed we can see better, operate at faster pace, suture better, and get rid of disease kind of like with more vengeance, if you like it. Why? Because when you see something 10 times bigger in 3-dimension and high def, you can extract it better. So we started doing these surgeries until we became pros in it. And when they started, they wanted to learn, the followers, we were way ahead. So we became a little bit pioneers in robotic surgeries. We crossed the 3,000 until now cases in robotic surgery. So I was recruited by the UAE government to come and start the robotic gynecological program in the UAE. And we did this. Al-Qasimi Hospital in Sharjah was the first by the MOHAB previously and EHS now, which is the Ministry of Health and Prevention, that acquired the robotic Da Vinci, our American robotic system. And I came. They used to do in 2014 cardiac surgeries. And in 2019, we started doing GYN surgeries, exactly September. So I spearheaded that department and teaching local Emirati physicians. And we graduated the first woman in the Arab world in May of 2023, Mona Kashwani, which is a pleasure for me, to contribute and to have the next generation do this kind of technology. All along, what do you do when you do something very well? People will look at you. And we wanted to create that good jealousy thing. So people were inquiring, what is this program doing? Let's do the same. So, and many other hospitals in the UAE started doing the same. Well, now, after 4.5 years, we have 15 robots. So it's a pleasure, to have these people mimicking a little bit what we've done to have access to more patients. And the patient will have access to more minimal invasive surgery. So my motto was actually started with a vengeance. And now it is kind of spreading everything. At my age, and you would say I'm young, but I'm 56. So we've done a little bit, and now it's the time to give. How do you give? You train other people and knowledge to the base. Who's the base? The patients. In our parts of the world, especially the Arab world, we're hungry for that knowledge. And women are underserved. No matter what you say, we're still in the back seat. We need to move them to the front seat. And we need to move the physicians who don't have access to these technology also to the front seats. So my quest is to educate and reach out as much as I can. If we create a little bit of good jealousy, let others do the same. And that's what we want.
Yeah.
Thank you.
And you want to create that network, I guess, that ripple effect, inspiring more people to go down these things because that can help more women and expand, what this technology can do. It's very unfortunate that, that was the spark of what motivated you to go down this field. But listening to your career, it sounds like you went through a lot of different changes. And like you said, you guys were the pioneers. You were the early ones in the industry, which is why it kind of like now when you came here, it kind of like took off. You've been a key player in making it more accessible to people all over, women, particularly in the region. Now, you mentioned that last point, which I think this is where we have to start the conversation, the education piece. Now, I'm just going to speak from my experience. So growing up in this part of the world, as a guy, I literally knew nothing about women's health. You could ask me what's a period, what's anything. I wouldn't know how it works, what anything does, until I got married. And then I was exposed to this whole world of women's health, and I didn't know that women suffer through these things. So the education piece, I think, is not just women need to be educated. I think society as a whole, as men too, need to be educated, as we need to be more educated as well, because then we can help our wives, our sisters, our family, when they're going through these difficult situations that we as men don't experience or don't understand.
You were spot on, when you said, well, I didn't know anything. And only when I got married, I got to know you're late in the game, but better late than never. But we want to educate you before, because before you get married, you encounter many colleagues, patients. Do you know that a couple of countries now in the world for a condition known as endometriosis now, they give paid time off 2 to 3 days a month?
Wow.
Because these women suffer in silence and no one knows about them. You know that the French president, Macron, declared like endometriosis as a national disease? I mean, there are things that women pass through that we would never know about men. You're not going to do that because you're not going to feel it. So the more you know, the better you understand. And the better you understand, you let them feel better. And it's all about making the other feel kind of accepted. When you feel compassionate about that and understanding their condition, you put them at a good positive spot, and that affects them a lot. People who are happier in their relationship take less antidepressant, less pain medication, less headache, sleep better, and you get less sick, right? I mean, we have studies that shows that happiness, especially in women, will increase the IgE, the immunoglobulin E, which is the good one, and they will have less viral infection. I'm talking about sinusitis, rhinitis, or all these upper respiratory viral infections. So basically, immunity plays a big role. I'll take you through another pass leading to another thing, cervical cancer. Let's talk about it. Cervical cancer is the third most common cancer in the United States, gynecological one. It's not the first, but in the world, outside the US and rich countries, third world countries, it's the number one killer in women. Almost 661,000 women in 2022 were diagnosed with cervical cancer. Out of these women, almost 350,000 died. 50%.
Wow.
Right?
Wow.
Right. But why am I touching base on cervical cancer? Because you need to know about it. Who are you? You're a male, right? You got married, correct? When you get married, what do you do? Tell me, what do you do? You form a family, right? To form a family, what do you do? Tell me. How do you form a family? You get intimate, right? With intimacy, two people get together, right? And what do? You get together, then you touch each other, right? Right. HPV, human papillomavirus, which is the culprit of cervical cancer in 99% of the cases, is the most common sexually transmissible disease in the world. All right? Give you an example. So, patient A went to college, right? Met her love of her life. His name is Bernard. Bernard had one encounter before he met patient A, who's Christine. Bernard had one encounter before he met her. Christine is a virgin. They got married. 10 years later, Christine has cervical cancer. Why? Because Bernard had one encounter, unprotected, caught the virus, gave it to his wife. 10 years later, with her immunity down, that virus caused an infection, was undetected, and progressed to be cancer. That's why if you hear about Papa Nicolau smear, it's a smear of the cervix. The cervix is the beginning to the uterus. And these women, my mom, your mom, my sister, your sister, my grandma, because it's been almost 60, 70 years that Pap smear, they do it every year. Why do they go to their gynecologist every year? They screen for cervical cancer. But only like 20, 25 years ago, we discovered that cervical cancer is linked to HPV. So we started now doing HPV screening on top of the Pap smear, which we name co-testing. And most recently, with the advantage of high resolution and ultrafiltration in labs, we can identify the types of HPV. There are more than 200 plus types of HPV ranked between high risk and low risk. So now we can do only HPV testing and stratify the risk of every woman. We didn't have that technology before. Now we do. When I came from the States here, it was a taboo subject. We couldn't talk about it. No, you cannot talk. Well, it's killing our daughters, mothers, sisters. What do you mean we can't talk about it? We need to talk about it. We need to screen them. Why? Because we can prevent it. If we catch it early, we can treat surgically because there is no treatment. There is no treatment for HPV until now. All right? Increasing the immunity makes it good. And HPV, let me be clear, if it affects young girls between the age of 16 and 21, and we don't test them, most likely 95% of that HPV will disappear. So they won't even know that they have it because the immunity overcomes it. But in the small percentage that it persists, and persistence of the virus makes the cell changes and undergo dysplastic changes that will take it to what we name low-grade, high-grade carcinoma in situ followed by carcinoma. So persistence of the disease, the status, and advancing of the age of a woman makes it unfavorable events towards the progression of that. Why am I telling you that? Because once we do the Pap and do the screening, and we know if she had it, we can continue to watch to make sure it doesn't progress into something. And if it becomes a high-grade lesion, we can take it off, cut it off. Now, what's most important to educate you, your brother, your cousin, your sister, my sister, is the vaccine. We can vaccinate against HPV our young kids before they become sexually active to protect them for the future. The vaccine protects now against 9 of the most common, causing around 80 to 85% of cervical cancer in the world. It proved 98 to 99% efficacy.
Wow.
This is unbelievable. We've
Wow.
never had a vaccine like that. Never. With no untoward side effect other than site of injection pain for a couple of days. I vaccinated my kids. I have 3. One of them is 6. No, because you vaccinate starting from 9 to 26. And now we take it to 45 years of age. So we want to protect that subset of population that may become sexually active one day. And it's a fact. They're going to get married. So cervical cancer is something big in our part of the world. It's a taboo subject, HPV. We need to discuss. We need to break the ice about it and then spread the knowledge, educate, screen, identify, vaccinate. Got it?
Well, first of all, I knew none of this. So this is all really fresh information to me. I didn't know that it was the 3rd most common, in the States, and it was that much globally. And I didn't understand where it came from, what are the causes, what treatments are available, because this is also very good information for, exactly like I said, for me to have now, inshallah, in the future when I have kids, if I have a daughter. These are the things I need to know these things. And it kind of touches on the relationship between a woman and her gynecologist. What I've learned in my experience with doctors, whether the relationship I have with a doctor is very important. And when you talked about the detection and the prevention and so on, most people I know that, most women I know that have their gynecologist, they've been together, they built a long-term, relationship of this. So the question I guess I start thinking about is, when do we start that relationship? Is it when they're 14? Is it when they're younger? Like, when should they start going to a gynecologist and starting to, I guess, prepare for, the future?
Usually, the kind of agreed upon, whenever a girl is growing and having her menstrual cycle, she needs to start addressing the issues with either the kind of a pediatric who has knowledge, deep knowledge in gynecology, or if not, especially when they start at a young age having their periods, the periods are never almost regular, because these are the 2 extremes of ages. We name it at the young age, the menarche, when they start having it. The hypothalamus, it's part in the brain, pituitary, ovarian axis, there's an axis, they talk to each other, is not mature yet. And it takes between 6 months and 2 years to mature at least. And that, when it matures, it regulates the periods. Meanwhile, mom gets crazy, what's happening with my daughter. Daughter gets crazy, what's happening with my period. They didn't tell me that. And pediatrician is not very familiar with that because it's all about usually vaccination, taking care of disease and stuff. So the confusion settles in. When the confusion settles, everything goes all, So basically, that's when you seek a gynecologist, Now, just to touch base on something that we talked about earlier, do we vaccinate both boys and girls against HPV? What do you think?
I don't think so.
Why?
That's a good question.
That's a man answer. And today, you're talking to Christine, okay? Of course, you vaccinate man. How would women get HPV? Man transmit HPV as much as women transmit to man. And man transmit to man. And women transmit to women. You remember what I told you? It's intimacy, touching. So it's a disorder not present in the blood.
Mm-mm.
It's on the cutaneous and subcutaneous area. So man and women, boys and girls need to be vaccinated. And then you protect everyone. And then HPV causes, you know what? Cervical cancer, anal cancer. And guess what? Vulvar vaginal cancer. And you want a good news and bad news? The good news is, maybe 10, 15 years ago, the most common cause of oropharyngeal carcinoma was smoking. You smoke?
I do.
Well, quit it. Most recently, HPV took over smoking as the cause of oropharyngeal carcinoma.
Wow.
And I leave it to your imagination to know why. All right? So we close the chapter on cervical cancer and HPV. Take-home message is vaccination, identification, screening, treatment and talking, to your doctor. We go to the young girl that starts having her period, needs to come and address the issues, whether pain, that keeps her out of school, or unsettling period with irregularities and dysfunctional bleeding. So we need to reassure these girls. And there are many young females have what we name polycystic ovarian syndrome, PCOS.
Which literally, I'm so happy you brought that up, because I was just about to jump. That would be where I was going to jump to next. So PCOS, doctor, is the one. I don't know a woman that doesn't have it. Now, from my perspective, the thing I've been thinking about is what's going on. I don't understand how it's something that is so common. So what I think would be very useful for the audience to understand is, what is it, what causes it, and what are the treatments? Because I think because even the women I speak to, they're like, yeah, I have it, but I don't know what to do. I don't know what to do about it. It's just, I know I have this thing.
Well, to tell you honestly, I don't know what causes it, because really no one knows. I mean, if we know we can prevent it, we can prevent it, we can treat it,
Okay.
Studies are being made everywhere to know what's the culprit in that, We don't know. But many women, but we know it's a disease of younger age, and then older age women. But we know that women present with either irregular periods, either irregular being less and less, or some PCOS present with normal periods, with peripheral ovarian small cysts at the level of the ovary. So if you have the ovary like this, at the periphery of the ovary on scan, on ultrasound, you have small cystic areas all over. Some of the women are associated with obesity, overweight, and some of them with hirsutism, which means excessive hair grows in unwanted areas. You get it side cheeks, around the nipples, at the level of the belly button, going down, at areas where women don't want to have hair. So some of the PCOS presents only with ultrasound findings with no symptoms at all. So the variety of symptoms that these women present is kind of mind-boggling, and we have to address each one as they come and present. Now, what do we do to treat them? If they are overweight, the best thing is to lose 10% of your body weight, and they may regulate. You don't need to give them anything. For women who are resistant to losing weight, or the regular period is so irregular that they can bear to live with that, we start them sometimes on oral contraceptives. And the reason for that is we want to stop the ovulation. We want to calm that ovary down. And with the hair growth, these oral contraceptives have estrogen and progesterone, and these sits on receptors in our body. And in our body, we have receptors this is a receptor, and this is the molecule. They sit on it, they activate it, and it starts working, right? So if I have these oral contraceptives consisting of both estrogen and progesterone sitting on these receptors, then her own hormones keep on traveling in her blood system, cannot find enough receptor to sit and act, and mainly the testosterone, These are all sex steroid hormones, we name them. So they don't create the hair growth that we want. So women, we put them on birth control to decrease almost 50% excessive hair growth, So we treat symptoms as they present. And if they have irregular period, the period will be regulated with birth control, loss of weight, taking care of the hair. And of course, if it's affecting fertility, then we will refer them to fertility specialists. But most of these women will overcome them, as they age.
I guess one of the biggest challenges listening to that is if the symptoms are so mind-boggling, and it's very hard to pinpoint, and we don't know the cause. I guess the next question becomes detection. Like, for example, with PCOS, is there any benefit to us being able to detect it earlier, or is it just one of those things that is just the same?
Well, imagine if you go and start detecting every woman that has a couple of cysts around the periphery of her ovaries, and you kind of label her as PCOS if she has no symptom. Who cares? Again, you got to deliver a positive message. That's not a cancer. That's a condition that presents in the ovary that may or may not present with symptoms. You treat the symptoms. Once we know the origin and we discover what causes that, maybe you can contribute. Now we know that overweight and obesity is a no-no, so we encourage all these young women to take care of themselves and shed some weight, the extra weight that they bear that may cause this. Taking you to this, as women are aging, the dysfunctional bleeding that was a benign nature when they were young becomes a pathological one when they get older. So any woman in the States above 35 years of age, and forgive me and forgive the audience if I say 35 is AMA, which means advanced maternal age, becomes an area of concern. Why is she bleeding now, unpredictably, so heavily, or not, when she didn't have that 10 years ago or 5 years ago? Does she have polyps in the uterus? Does she have hyperplasia or a beginning of cancer? 2 days ago, 39-year-old uterine cancer. Uterine cancer is the most common gynecological malignancy in the United States. Most common. And it kills. Gynecological. Breast is the second. Guess who's number one? Guess. Something common with man.
Testicular cancer, I guess?
No, common with man. Women and men have the same.
Lung cancer?
Yes. Lung cancer is the number one killer for female in the US, and that's what we suffer from. And due to what?
Smoking.
So you are?
A smoker.
All right, thank you for that.
Fair, very fair. On the point you made about, so I'm happy you brought up the breast cancer element. So I was doing some research and I looked at statistics. So it's the most common cancer among women in 157 out of 185 countries. And on the current trends, apparently by 2050, there's going to be an increase of 38% and an increase in deaths by 68%. And it's disproportionately going to affect women in less advanced countries compared to the more. Now, breast cancer, again, the question I struggle to wrap my head around is, it's the level of commonality. You know, I know like lots of women now, I know breast cancer went through there's a big movement over the last like 20 years. A lot of awareness came onto it. I know most women I know get checked, regularly to make sure all is good. But I don't know if you have the answer to this, maybe we don't. Number one, why is it so common? And based on this data, which I hope is right.
No, I hope they're wrong.
Yeah.
This is a projection data.
Yeah, I hope.
So we don't want to go there.
No, yes, we don't.
We know it's very common,
yeah,
as you said. And we know that we've been detecting it more and more. And are we discovering it because we have better detection methods and we didn't know about? So that's also an epidemiological factor that needs to be concerned.
That's a good question.
And in parts of the world, it's different, and rich country is different than poor countries, And a very important thing is behavioral modification with diet, and smoking and all the environmental factors that go with that. And babies, pregnancies. When you have a woman that is pregnant and delivers babies, you stop the ovaries. You rest them for 9 months. Then you take the same woman, she's breastfeeding for another year. You rest it. So you have less cancer, breast cancer, It's very important to know why, because most of the breast cancer is estrogen dependent. That's why women with breast cancer, when we operate on them and take the breast cancer away, the lump in the breast, we treat them with what? Unless it's localized, and the margins are free and everything is okay and there are no lymph enlargements and everything, we treat them with medication, chemo, and radiation. And then we maintain them for a couple of years, at least 5 to 10, on pills. We name them tamoxifen, which is the most common one. Why? Tamoxifen is an anti-estrogen.
Oh, okay.
So here we have women who are 30, 35, 40. We took a small lump from their breast, but it's too late. We radiated the breast, we give them chemo, and then we put them in menopausal status at the age of 30 and 35 and 40 for the next 5 years. So not only they are suffering from breast cancer that they overcame, now they're living in menopause 20 years before. they're miserable. Their vaginas are dry, their sexual life is affected. They feel down, they have insomnia, they have hot flashes. I mean, this is major. So hence our role here, this is another subset of population, not only the cancer that affects women, but the cancer survivors that are affected by the conditions that got treated, because most of the breast cancer are estrogen receptor or progesterone receptor positive. So you need to give anti-hormonal medication. There is a subset who are triple negative or something that you can't give them this, you give them other medication. And then we have advancement in medication and delivery of technological medication with immune-related and immune modulators. But still, there's a big subset of treated women who are miserable, and we need to treat their symptoms that arise from these treatments, So yeah, it's a big thing. Breast cancer is a big thing. And we're looking at diagnosis more and more.
So I once read a statistic that, I think because you touched on it earlier, different parts of the world will have different statistics and different processes with this. That I'm paraphrasing here. It was something like, in the UK, it's 4 in 20 women will have breast cancer breast cancer. And then for example, Japan, it was like 1 in 20. And they were talking about why is it different, And it comes down to, or what they were talking about is the environment, the food, and all these environmental factors that could be contributing to this. So I guess from your experience, how significant is that towards these conditions?
It is significant. We can see environmental impact on kind of every type of cancer. Truly, it is an impact that the environment has. And we believe that's why smoking is one of the biggest ones. When you drive your immunity down, you let everything goes up and flourish in a surrounding area that is not compatible with healthy tissue. So you start, what is a cancer cell? Well, let's talk about cancer.
Sure.
Every cancer has the same thing, Cancer cell is a cell that undergoes crazy behavior. Just went crazy.
It multiplies like crazy. Yeah.
All right. So that you have that DNA that along their transcription method underwent a kind of a misregulation of their genetic and started proliferating in a chaotic way. And that opens up the gates for everything. So we touched based on breast cancer, but let me just take you on one thing which is related to AI, artificial intelligence and breast cancer. Now, I was given a talk in Jordan almost 9 months ago on robotic surgery at King Hussein Cancer Hospital Center. And I was really taken by a lecturer, a professor from the States, that gave a talk about AI and breast cancer detection. And I was like saying, wow, now you have models of data mining of millions of scans done all over the world that now try to interpret a scan in front of them, And when you have an AI read, so you have millions, in that AI chip reading, and they came out to detect better than the human radiologist, because now you have maybe 1,000 radiologists input into one chip versus one reading it. So imagine if we screen our mass screening and we can feed that, so we don't have to wait until someone sits for 20 minutes to look at the breast and analyze it. You have a chip reading it in like a split of a second. Unbelievable. So you probably will detect more in the future.
So I'm happy you brought AI into this, because obviously I know one of your main areas of expertise is the robotic aspect. And doing surgeries, using the Da Vinci that we talked about. So I wanted to start with this. AI, robotics is almost like a match made in heaven. It's almost like they were designed to be together. But now when I think about it, I'm like looking forward, you touched on it earlier in the conversation, like, oh, this will replace surgeons and stuff. Maybe back then, no. Now with AI, I don't know. So I guess what I'm trying to think about, or what I was when I was doing my research, is what does the skills of a future surgeon look like? Because, okay, yes, you need to cut and whatever, but now if I'm using the robot to do the incisions, I have like the medical knowledge, but you have to be more of like like a technician. I don't know how to explain it. So where do you see AI and future, like how that translates into the skills future surgeons are going to need in the next 5 to 10 years?
All right, listen, I told you my age, right? There's no secret. So I walked the walk through the past of doing open surgery,
Yeah.
which means I take a knife,
Yeah.
I cut the skin, I go under the skin, I put my hands, separate the muscles, go to the fascia, then go to the peritoneal area. I'm being graphic, but that's the truth. Then go inside the belly and then ask one assistant to come and put kind of a sterile towel inside and then move the bowel and then do this. And another medical student will come from that, which I still do sometimes, and I'll tell you when, to laparoscopy. And then a camera came along where we can look at something inside from far away and we can see it on screen. I was like, wow, what is that? So back in Atlanta, we did everything laparoscopically, you know. And
even I've had laparoscopic surgeries.
yeah.
Yeah.
And then I finished my fellowship in 2001. And then the robot came. So it came after my fellowship. And then instead of seeing 3 times bigger, now I can see 10 times bigger. And then instead of seeing in normal depth, now I'm seeing in high depth. And when I put my face first within that immersive vision, I get scared shit. And there's a simple reason. I never saw anatomy like that. I mean, I do a one-dimension anatomy when I do cadavers in medical school. And it's to say one dimension when I do open surgery. And now I have a 3 magnification in laparoscopy. And now I have everything around me in 360 degree. I'm like, what is that? What did I study this vein or that nerve that's too small? Now I can see it so big. Wow. What if that eye that I'm looking at into that body, looking at that uterus and the veins and the ovaries, what if that data of me looking there is being captured? So my name is Dr. Riachi. He is capturing my data. Let's name him X. What if X goes to every single room that does uterine cancer surgery, ovarian cancer surgery, fallopian tube cancer surgery, vaginal, vulvar cancer, and X captured every data of the top 10,000 surgeons in the world. All right. So X is capturing data. That's data mining, right? All right. That data, we take it for every patient that we operated and we go back. What's the name of that patient? Melanie. Melanie had uterine cancer. Right. Let's look at her MRI that she did at Boston General. Well, let's X. Take every single Melanie that had uterine cancer with these 10,000 surgeons and go backwards. Capture the MRI data. Capture the history of the physician, whether John Doe or X or Y or Z took it. Every history. The nurse that took the vital signs, you know, the patient's lab that they were done before, the pathology afterwards, the blood loss, everything. Data mining of this immersive data about these patients. And then put them in a chip, right? Tiny chip. And then 10 years from now, I'm operating with we have now 5th generation of the robot. So let's say in 10 years, we're going to have the 10th generation. And then that eye, I put it inside the pelvis. And that eye is looking at that ovary. And then I press, I say, X, what do you think? And X will say, well, Dr. Riachi, you know what? That ovary is not good. It has a lesion that looks like a serous carcinoma of the ovary, 10 millimeter in depth from the serosa on the outside, and then no spread around it. I don't see any lymph nodes, I don't see any spread. What do you want me to do? Just take the ovary alone? Or I'll take the ovary and the tube? Or do you want to do a hysterectomy? And I'll press one button, take the ovary alone. And then you will see the robot being active and going better than me, because that robot is 10,000 surgeons doing the best surgeries in the world in it. So that is the future of data capturing, data mining, collection of that, analyzing everything, and let it look at something and give us the best of the best. That's full active robots. Right now, we don't have. You know what we have now? A master slave. You tell me, what is that? I'm the master, the robot is the slave. All right?
Yeah.
It's a master-slave relationship. Then there are the semi-active robot. We have them. It's in neurology and neurosurgery. If there is a tumor in the brain, you know, they will map it and they will ask the needle to go in and get that biopsy. But we don't have full active robots now. But AI will be developing into that. What's my role? Probably my role is to park the robot in the future and make sure it's working well and document the data. This is years from now, but this is going to happen. It is going to happen. The future is unbelievable. It's how we're going to put brakes to go slowly and steadily instead of jumping into something that may hurt us, not benefit us. So it's very important. I see the future, you sitting in front of a machine, looking at it, analyzing your face, and if you have a cough, something will come up and you cough into it. It will take your droplets, analyze them, and tell you you have pneumococcus pneumonia and you need treatment with this antibiotic, and then come and see the doctor 2 weeks after. It's going to be unbelievable.
So do you see it's fascinating that it can take from all of those and apply it into, you know, like the learning that you can get from that. And as I was listening to you, I'm like, it must be so surreal to have theoretically studied something for so long, to see it, you know, with all this imaging and with that much clarity, probably also opens up new findings for you as the doctor. Like, oh, I didn't know it went like that or did that.
I'm going to take you there. So when you tell me you went like that and you went like this is what leads us into endometriosis. Endometriosis is a condition that happens to many women between the age of probably 18 to 40. It's a kind of silent disease as we describe it, but shatters women's lives all over. You know, it makes them not living properly, in pain, you know, not being able to be intimate with their partners, suffering in silence, missing work, taking medication, even described by their peers and parents as psychotic, you know, because they are out of this world with the pain and no one believes them. Endometriosis is a disease where blood that comes from the lining of the uterus inside, we name it the endometrial cavity, that's inside the uterus, lined by the endometrium, you know, the one that everyone, me as Christine, bleed every month, you know, from. Blood comes out through the vagina to the outside world, but some of it sometimes goes into the uterus, into the tubes, which are open into the pelvic cavities and kind of populate around and create implants of endometriosis, or inside the ovary, creating a kind of a blood clot, if you want, which is a big mass in the ovary named as endometrioma, you know, and causes pain, pressure, infertility. But these implants, they can go and populate different areas up to under the diaphragm, you know, and we found endometriosis actually in the nose of patients, in the umbilical area. So some people have a menstrual cycle and they bleed from the umbilical area because they have a nodule of endometriosis there. It's present also in the vagina. There's stage 4 endometriosis. Is very, very, very complex. And I need the robot for that. You know, I used to open patients in the past, and I know my mentor, a couple of cases, we open and we close the patient. He said, you can't operate. We need to be well prepared for that. We need to call the urologist to put stents in the ureter because everything is covered. We need to call the colorectal surgeon because there may be involvement in the colon and we need to resect it. With the advantage of robotic surgery, now that we can see much better, and when you tell me go like this or like this, the instruments go in a 360 degree. You can go down a view and go around, you know, the lesion, pull it up. So we're doing more advanced cases and we're trying to save more women, you know, from suffering. So it's very important that technology allows us now to go further and do more complex cases and render them easier to do. Forgive me, but my heart races at 200 beats per minute when I do these cases.
Yeah.
But I want to do it because I wanted to make the difference. These are not easy cases.
So with endometriosis, I think I'm so happy you brought that up because I know that's also a very common one. Now, I know PCOS and endometriosis are different.
Totally.
But so when it comes to endometriosis, when it comes to detection, treatment, solutions, what's the information that people need to know about it?
All right. Endometriosis, when diagnosed properly, and I say when diagnosed properly because many of them go undiagnosed, and they suffer for years. So if it's obvious by ultrasound that the lady has an endometrioma, which is the blood collection within the ovary, or if the ultrasound is very good and they detect implants around it, or if there's thickening or adhesions in the pelvis, then we know she has it, right? But what if she doesn't have any of these? The ultrasound is clear. I had an Italian patient, and she works at Emirates Airlines, and she's in pain all the time, and no one is believing her. She did an ultrasound. She did even a pelvic MRI, which is magnetic resonance imaging. They take cuts of 1 millimeter imaging, reconstruct them. So it's the best, available that we have, imaging technology. And it's negative. Now, maybe the person who read it didn't read very well. I don't know, but it's negative. So I said, you know what? I believe you. What we're going to do, treat and see if she gets better. But the treatments, we're going to talk about them is a little bit more from A to Z, where you want to treat. I said, you know what? Let me take a look. Let me put a camera inside the belly, one hole, and let me see. And there, I go in, I put a camera, and I put the robotic camera because I see much bigger, and I see washed out lesions. That means they couldn't be picked up on ultrasound, small, tiny, less than 3-4 millimeters lesions on the bladder, behind the uterus, on the ovary, on the side wall of the pelvis, all over. Tiny lesions. They're not going to pick them up. They're not going to see them. Our lady is not crazy. It's a genuine type of pain that was disregarded for years. She was on sleeping pills. And guess what? Uncontrolled substance medication and tramadol all the time. We operated, we took all these lesions, and now we know. Just knowing that she had it probably cured her 50%, from the agony that she has been suffering for years. So that is disease treated surgically. But we have many cases that they are benign. You have ladies with endometriosis, they come with big masses, they don't know that they have them. They're asymptomatic, So we treat when it affects fertility. That means the ovary is compromised. All right. We treat when there are symptoms. I treat symptoms. I don't treat conditions that look on ultrasound something. If there is a small endometrioma or a small nodule and the patient doesn't care, then I don't care. We'll watch it, okay? Endometriosis affects also intimacy. It creates a lot of dyspareunia, which means painful intercourse. And some people get distant, and it affects the couple. So we need to treat, So pain, infertility, pressure, and the most important thing also at what age they present. If they present at an age which they completed childbearing and they have stage 4 endometriosis, then the definitive diagnosis is to clean everything, have surgery and remove everything. At early stages, there are some medications. We use medication, we can put them on birth control. Sometimes we can put Mirena, an IUD, intrauterine device that's placed in the uterus that secretes progesterone. It's usually done for what? For protecting from getting pregnant. But we don't use it for this. We use it for the release of the progesterone to make the lining of the uterus very thin. And that lining, when it becomes thin, within 8 months to a year, women stop bleeding, stop menstruating. When you stop menstruating forward, you're not going to menstruate backward. What we name retrograde bleeding. I'm just saying it in layman's terms so everyone can understand. So endometriosis is a big condition. We need to address it. We need to educate both patients and surgeons. And you can tell me why surgeons, Dr. Riachi? You know that. It's your colleagues. No. OBGYN is what? What does OB stand for? Obstetrics, GYN gynecology. They study 4 years, and people are going to be upset when I say that. Within 4 years of residency, they deliver babies most of these years. They do almost 6 months to a year of gynecology, right? All right. Then they are out in this world practicing. They're amazing obstetrician, but they're average gynecologist. Why? A general surgeon studies in the States at least 5 to 7 years in general surgeries, taking appendixes, thyroids, colon every single day. So, would you give your mom or your sister to someone who did only a year and a half of gynecology to take a major uterus, or to someone who subspecializes? So endometriosis are difficult conditions. They need pelvic surgeons, means OBGYN that's specialized or subspecialized, or GYN oncologist in advanced disease, because it's a multi-specialty disease. You have to call probably the urologist, as I said, the colon surgeon, difficult surgeries. Everyone should have a referral base to the specialty that they feel comfortable with, and it's important.
I'm so happy you give us clarity on endometriosis. It's something that I've heard a lot of women I know have. I've never understood the risks. In this whole conversation for me personally as Khalid, this has been like a big, shone a light on so many things I didn't know, so many stories I've heard that I'm like, why? What's going on? Like, why is it a problem? But now I have the context to go back to those people and be like, sorry, okay, let's have a different conversation now, because Dr. Labib has given me all this new information. Now, you touched on birth control. So this is something I've spoken to many, many, many women about over the course, of my life. And I get very varying mixed responses, views. Some say, yes, it was good at the beginning, but then later on it was causing me all these issues. Some women that had the IUD took it out, and then it was a whole other set of issues. And one specific woman asked me to ask you this. From your perspective, does birth control affect women's health more positively or negatively long term?
I get this question.
I'm sure you do.
Every day, birth control pills. Let me start from zero. Anything you take that's manufactured somewhere is not as healthy as you want to be.
Fair.
Right.
Okay.
Anything.
Let's start there. Fair.
Okay. A birth control pill is a pill that has both estrogen or progesterone. Some of the newer pills are only progesterone, pills. But they're meant to stop the ovulation. We have 2 ovaries, usually. One will ovulate this month. The other one will ovulate the second month. We want to shut them down. By taking the birth control, we're taking iatrogenic from outside our body, estrogen, progesterone. The body recognizes that we're getting this, so it tells the ovaries, relax, I'm getting this, so stop producing anything. No more ovulation, no more cysts, no more corpus luteus cysts, that's what we name. So they relax. By relaxing these ovaries, you make the lining of the uterus predictable, because you're giving every day the same dose. That's why at the end of the pill, there are placebo pills or no pills, and the woman would shed. And if you take them 3 to 6 months, they will shed less than before taking the pills, because the lining is built in a predictable way. Now, my wife in New York and in New Jersey, working hard between kids, I put her almost 7 years on continuous birth control pills, which means that last lag of placebo pills, we threw them and we started a new pack. So you can take either the pills in a cyclical fashion where you bleed every month, or in a continuous fashion, taking active pills every day for 30 days, so you stop bleeding at all. You won't bleed. It may take you 3 to 6 months to adjust, but then you stop bleeding. When you do this, in both conditions, what did we do to the ovaries, Khalid?
We shut them down.
We made them sleep. When you make the ovaries sleep, what happens? You rest them. So the good thing about birth control pills is you decrease the chances of ovarian cancer. Okay. Even if you stop the pill after taking it for 2 years, the risk will continue to be decreased by almost 40% for the next 5 years. Because you rested something. It's not You remember? Every
Yeah,
month,
yeah.
and someone will go chaotic. So that's one big advantage of the pill. Second advantage, you bleed less. You have less cramping and less pain. So these are advantages. The disadvantage, and the main one, is DVT, deep vein thrombosis, which means blood clots in the veins. All right, like let's say a young 19-year-old athlete on birth control pills for PCO, not even for something else. Comes to my office, her mom brings her, and when she brings her in a cast. She fell and she put a cast on her leg. And I look at her and I was like, what are you taking? Well, I'm taking Yasmin, let's say. Or like, stop it. Why? Well, this leg is not moving. So whenever you don't move, you're prone to form blood clots. That's why when they tell you when you go on an overhaul flight for 6, 7, 8 hours, what do you have to do?
Move your ankles
Why?
and your hands so the blood circulates. Yeah.
Because what?
So we don't get blood clots.
So women who are taking blood OCPs are prone almost 8 times more than the general population to form blood clots. Now, take someone like that with a broken leg and a cast, multiply this, you can lose this patient by having blood clot that goes from her leg to her lung, then to her brain, all right? So DVTs, are a big thing in birth control pills. Same for hormone replacement therapy. Same for, we don't give birth control pills for women above 35 who are smoking. It's a relative contraindication to a contraindication. You don't, because smoking will enhance also blood clot. You smoke, right?
I do.
Good, okay. So, so basically,
Can't wait for the smoke after this one.
so basically, oral contraceptives has a lot of good things and some bad things, So we only give it when there is a need to. And if you're talking about prevention of getting pregnant, I think the best method is a condom, because you prevent from STDs. We just talked about the most common STD in the world, which is HPV, human papillomavirus. So, and condoms will protect almost 97 to 98%, So it's very important to know that.
Yeah.
I had a patient the other day, and I think probably you may not ask me this question, but I'm going to tell you because she came in happy, and she called me, "You're my angel." And I was like, wow, it's the first time someone tells me that, but I want to be on earth. I don't want to go up. And I said, why are you so happy? We operated like 6 months ago. She said, yeah, but I just competed for dancing, and I won. I said, okay, but I competed for dancing, and I won because now I could do it. And before the surgery, I couldn't. And I was like, okay. She said, Dr. Riachi, you operated on me because I was leaking. Whenever I cough, sneeze, I was losing urine. And I stopped exercising. I stopped training for dancing. And 6 months ago, you did the surgery, and I don't leak anymore. So stress urinary incontinence is a big taboo subject, and it's not talked about. And many women suffer from it, especially after they delivered their babies. This woman is like 37. She's a runner, she's a dancer, and she couldn't live her life. So this is a big thing. So we need to address these issues after delivering babies, after just getting old, the prolapse, the incontinence that affect women in their whole intimacy, and they don't dare to speak about. In the States, I don't know if you know Bonnie Blair. Bonnie Blair is the 6-medal Olympian skating champion, the only woman who had 6 medals at the Olympics. Bonnie was leaking. We did a campaign. I did it with her on breaking the ice, because she's an ice skating champion.
Nice.
To correct and fix the incontinence in women. So this is a big taboo subject, and not many women talk about, and we should, highlight that
Yeah.
women suffer from these things. And I'll just give you an example. If a man leaks, what does he do? He breaks the door that same day, goes to the doctor. Women, in silence, they suffer. They don't say anything unless you start asking them. They say, oh yeah, You're right.
And I'm so happy you gave us that context, because earlier in the conversation you said just understanding is already 50% of the thing. Because if you don't know, you have all these symptoms, you don't know what's going on, it's incredibly frustrating, man or woman. I know there's something wrong with me. I'm getting all the tests, but I don't know what's going on. I had this myself when I was having like stomach issues. I went to every doctor, every test, colonoscopy, whatever you want, did it all, nothing. And then I went to my chiropractor, ironically, and I was telling him, yeah, I've done all this and I don't know what the hell is going on. And he's like, how's your gut health? Just as an example, I'm like, I don't know. So he's like, let's try this. So he gave me, probiotics and, a couple of other supplements to take. Doctor, night and day. And once I understood I'm like, oh, that's the problem. Great. I can put in effort and work towards it. I wanted to round off on this question, or with just two more questions for you. And this is one that I only recently learned about. You touched on it earlier, menopause. Now, I didn't know until I watched podcasts about this, how significant of a period, that's not the right word, but like phase that is for a woman, like biologically, chemically, estrogen, like you're biologically becoming a new person. And I think I've spoken to many women or had people on my podcast that have said, no one talks about this. Like no one knows, there's not enough awareness about that phase and what are the therapies that you can do to go through. So maybe I think this would be a good topic to round off on the health aspect.
We touch base on that with women with breast cancer at a younger age when I told you that we put them
into menopause,
in medical menopause because we give them medication that will induce menopause at an earlier stage. But these are the same symptoms, whether we induce them forcefully with medication or surgically. If, God forbid, there's a cancer and we need to take the ovaries of someone who's 35, then they are in menopause, right? Surgical menopause. But the natural menopause that you're insinuating at is the menopause that goes and comes in an area which name is perimenopause until it comes and stays as menopause. And this can vary. Any woman after the age of 40 who starts fluctuating her menstrual cycle, feeling hot flashes, some insomnia, short temper. If you're talking to me now, we're talking almost for an hour and I'm getting like, that's it, I don't want to talk about it. I mean, I used to do this for 2 hours and now I can only do it for 1 hour. Remember, I'm Christina, right? So I'm in menopause. So I'm short temper. I don't sleep well. I have hot flashes. I can have one of these or all of these, okay? And dryness. So my skin is mottled, it's changed, I'm drier. My vagina is actually dry. I can't tolerate having intimacy with my partner because it's painful. All of these are big changes. I mean, this is like a hammer coming on their physiological health immediately. Now, you have women passing through menopause and like a breath of air, nothing. And you have women having one of these symptoms destroying their functionality, and affecting their intimacy on a daily living. And that creates another corner for women, that they will feel that I'm stranded there and how do I come out of it? Out of it means addressing it. Addressing it is talking about it. If your doctor doesn't, you talk. And if the doctor neglects it, you move to another doctor. So you have so many physicians, they are comfortable in menopause and in these, lifestyle changes that you can have access to them. So if your obstetrician and gynecologist that took care of you for the babies doesn't have time or she doesn't have time to address these symptoms, you need to address them with someone who can. And what do we do in this stage? We analyze their hormonal milieu. We make sure they don't have thyroid disorders. And a woman may present with symptoms of, hot sweats and stuff. She may have thyroid disease, not menopause. So you need to make sure that they have the right thing, And when they do have menopause, and we make sure by hormonal milieu, first of all, menopause is defined as 12 months of no period or an FSH above 70. Above 25, it's going into menopause, but perimenopausal status. And perimenopause can last from 6 months to 5 years,
Oh, wow.
And it can drag. So most of them, it's within 1 or 2 years. But they are living these transitional period and symptoms that we need to address. If the vagina is dry, we can give them creams. You can give estrogen cream. You can give hyaluronic acid tablets. You can give ovules. You can do PRP, platelet-rich plasma. You can take it from the blood, do injection in this area. There are a lot of things. And now we're using also exosomes. So there are hormonal treatments and non-hormonal. What you want to listen, what does you want? Hormone or no hormone? It depends. If the breast is good, because all the hormones, HRT, may cause an increased risk in breast cancer and uterine cancer. So you want to measure the pros and cons. You can't give anyone who has a breast abnormality hormonal milieu.
Sure.
So we treat the hot flashes, with environmental changes. Stay in cool areas, wear light dresses, okay? And if it doesn't work, we give other medications that are non-hormonal first. We know about the medication, like we have it in the States, the name is Brisdel, but it's the same medication that we give for anxiety disorder here. It's paroxetine hydrochloride at a small dose. At 7.5 milligram, the dose, which works for vasomotor symptoms of menopause, the hot flashes, it decreases almost 50 to 70% of the hot flashes without giving her hormonal treatment. If everything fails, we start HRT, hormone replacement therapy, and we monitor the breast and we talk about it,
Yeah.
So basically the HRT that we spoke about, is hormone replacement therapy. It could be delivered in multiple ways, either by pills, which is a systemic effect that goes through the liver, get biodegraded by the liver and delivered through the bloodstream to the organ system to do the effects, whether on the skin or the vaginal area, on the well-being, etc. The other mode of delivery could be patches. It's more of a transdermal thing, and it bypasses the liver metabolism, hence a little bit less side effects, from it. And then you could be transdermal with creams or gel. So there are lots of methods of delivery. So you got to choose between either hormonal or non-hormonal. But there are things that we address to make women feel better and much better.
And so I wanted to round off. So first of all, thank you for giving us that context of the different therapies that are available to women, because these are things that I hear about, from the people in my life and so on. So this is great information to me. So I can now go back and tell them, guys, now I know so many things. Let me explain. I wanted to round off our conversation today, Dr. Labib, with this. Now, I know your journey into medicine didn't start from a conventional sense, with the story that you mentioned earlier in the conversation. But now with AUD, we're launching, the new biology program, and inshallah in a couple of years, the med school will be launched as well. So, and I've spoken to doctors on the podcast before, and they've told me the importance of picking your specialization, then you have to subspecialize, and within that, you have to subspecialize again to find your niche. So what advice, I guess, would you have to the students now about to enter, a program like, we have here AUD, or entering the medical field, given the stuff we've talked about with AI, how things are changing? Because I feel like the rules or the advice that maybe once upon a time we would have given, now in this new environment needs to be updated, let's say.
It is a question that follows time and evolution of everything. If you specifically talk about AUD, you are blessed here because you kind of came in a fashion that's a little bit more of futuristic. Why would I say that? Because now you're studying on iPads, you're looking at screens, you're interacting via telecommunications, you're using in your lab a VR, right? Virtual reality lab setting in science and biology. We never had these choices. We never had simulation. We had a book and a pen, and we're looking at the teacher all the time, So basically, it changed to a futuristic area, but now it's the present. And the future will be better with, like you said, AI and integrating knowledge and stuff. But the human factor is the most important. Whoever is entering the data or collecting all of this is a human, right? So whatever is interpreted by that ultimate machine type of learning is from human experience and human resources. At AUD, if you're walking the walk from biology to medical school, that's going to be something new, like a newborn, right? you're doing it the right way from the beginning. So set your priorities straight, you know. Are the students who are dedicated to spend between 10 and 15 years of their life dedicated to science and to others present in that pool? Are you graduating the biology student to have a 20 to 30% to med school and the rest to science, you know, whether pharmacy? Know where you are from the get-go. Do your statistics, because your acceptance for the next years is going to rely on this. You want people to be committed. Plus, we are in an environment where there are a lot of expats. It's a welcoming country where everyone comes and educate. But now it's turning to be that people are loving this country and staying and working. So you want these pool of students that come, a lot of them to stay and give and contribute, because AUD will only thrive with the community that graduates from. So the grads will contribute for the future, you know, because now the students are doing the present, but the future is dictated by whoever finished and has the best memories at AUD to come back and say, you know what, my cousin should go there because I had this, or I will support this program, you know. With my experience in the States of almost 34 years and studying and working and everything, when I got approached to be part of the education and the support, I never thought about it because it has my kind of thinking forward that I had back when I was a kid, you know, wanting to do this in the States. But what do I tell my kids? That's the most important question. To me, my son, Edison, Eddie is a business major. I won't push him into medicine. Either you fall in love with what you do or you don't. I spend hours. I'm the guy here that operates at 6 p.m. And everyone was like, what are you doing? I said, so what? So 6 p.m. surgery is not surgery? What do you mean? You got to do the surgery, you got to do surgery. I book elective cases after office, before office, during the day, in the evening. I don't have set time. It's not you're operating to play golf after or to go to the movies and do things or dinners. When you're committed to this, that's it. Unfortunately, I will finish with this. Behind the mask, like I told you at the beginning, there is a human being. So behind the mask, that doctor is a human being. They feel, they sense, they relay information, and sometimes they don't say anything. So yes, we are here to heal others, but so many of these physicians that went into that field without the commitment or for the wrong reasons are ill inside and they need help. You know, either they don't sleep well or they're tired most of the time. It reflects on their families. So telling the future AUD students, you want to go into medicine? Fall in love with it. If you're not in love, don't go. You don't know? Stick and rub to one of us. Come, spend 2-3 weeks with me. You may faint in the OR, or you may love it, or you may say, I don't want to do this. Thank God you showed me this, because that's it, you know.
Sure.
Or other surgeons, or other doctors, or spend time with colleagues to know, do you really want to do that, you know? And then my advice is just go forward with whatever you love.
Well, Dr. Riachi, thank you so much for coming on the show today, for giving us that context, the point you made at the end for future students and the program here at AUD. So my younger brother is a doctor. You know, I see everything you talked about is what I see in him, the level, the hours he puts in, the commitment. You know, he works 12 days in a row. He's in his second year, so he's still the beginning of his journey, and he wants to go into neurology. So a lot of the things you were talking about and what the future of imaging looks like, I was thinking about him. I'm like, I wonder how he's going to use it. So it was very interesting for me to hear that, to get some context, and also for all the amazing work you've been doing, you know, championing not only the advancement of these technologies, but helping women understand themselves and what the treatments are, and that they don't have to, you know, suffer in silence. So I want to just say, for myself and I think for everyone, you know, at the university, thank you so much. This has been an absolute pleasure. And anyone, whether you're a father, husband, boy, girl, whatever, anyone can learn a lot from this conversation. So thank you so much.
Khalid, thank you. Thank you for the opportunity, one. Two, thank you for you guys doing this. I heard from you that you guys have been doing it for a couple of years now. Continue, you know, this is an excellent podium where you can push the knowledge forward and expand it, you know, to others. And we have to teach the many, not the few. And your venue is one of them. So congrats and thank you for having me.
Thank you so much, Doctor. We really appreciate it. Guys, to everyone listening, thank you so much. And we'll see you next time. Take care.